the link, maybe you can see. The link, maybe you can see. Okay, we are online in YouTube, and I will give you the command.
Okay.
And you can put your presentation. Okay, Doc, you can put your presentation.
I'm seeing if I can pull it up here.
Okay. Oh, nice sky. It's okay. Okay, we are ready, but maybe we can wait a little bit.
Sure. Is that still working for you, John?
Yeah, it's okay. I can see very well, and I can see you very well also. Mayo Clinic, innovation in pediatric urology, right?
Yes.
Good.
Unfortunately, it's the things we've probably done wrong. So,
Yeah, but online connection maybe sometime get wrong, but it's okay. Normally, everything is okay. Which is the area you like the most in pediatric urology?
um, actually, probably the congenital or the transitional care is what I've done the most. So, taking care of adults with pediatric problems,
Mm-hmm.
certainly my most experience. Not what I intended to do originally. It's just unfortunately how my
And
practice grew.
I've been talking with a friend of mine, Dr. Elio Buston from Brazil, and we were talking about the problem that to get this child and pass to the adult control is very difficult for us sometimes.
Oh yeah, it is very difficult. That's true here in the States, mainly because the patients, unfortunately, usually don't have a lot of insurance, as you mentioned.
No, you got to find the perfect people to take care of them, right?
Yes, that is very true.
Yeah, we do something like adult with child pathology. I do in my
Uh,
hospital because I don't have this opportunity to pass. Sometimes nobody wants these patients. Uh,
that's
Most
right.
of them with chronic problems.
That is correct. Yeah, if there's a problem with the presentation, don't hesitate to interrupt. So,
No, no, it's okay. Normally we expect to finish your presentation and then I pass to you the questions.
okay. And how much time do we have, Turn?
Yeah, you can take your time, 40 minutes, 50 minutes. It's okay, no problem. Normally we reach 1 hour presentation.
Okay.
Yeah, it's okay. Time you feel comfortable. I don't need to run.
Morning, German. Good morning, Doug.
Oh, Tony,
How are you?
there is the guy. This is the T-shirt of Bolivia, Doc.
Is that right?
Soccer shirt. That's right.
And actually, I don't know the word in English. We passed to the second, I don't know.
Brown.
Help me, Ellie. We passed to go to the World Cup in USA, but not really into the USA. We have to one step before to go back.
Yeah. One more
Yeah,
step.
we are on. on the way.
Excellent.
Yes. Okay. People is coming normally. Okay. We finished the program for the next year. Finally, Tony.
Yeah, it took a little bit of effort, but I think it looks great.
Looks great. Yeah,
It's
yeah.
certainly very, very full.
I am socializing it in South America, in America,
Yeah,
from Mexico below, and they like it.
excellent.
So we are on time. Let me do your introduction, please, Doc.
All right. Thanks,
Okay.
Jim.
Okay, I will do it in Spanish, please. Buenos días a todos. Muchas gracias por su presencia. Como siempre, tenemos nuestro invitado, un experto en el área. En esta oportunidad, el doctor Douglas Husman de Rochester, Minnesota, quien ha tenido la gentileza de estar presente en nuestro webinar, que ya lleva su sexta versión, sexto año, y agradecemos, estamos muy agradecidos con su presencia. You are so welcome, Doug. Please, you can command the presentation.
Well, thank you for the introduction, Jim. So we're going to talk today about some innovation in pediatric urology, and specifically about how a transitional or congenital urologist looks at the problems that have developed in childhood. So two innovations have had a huge impact upon our transitional urology patient population. The first is actually maternal ultrasound, which became a routine standard here in the United States in 1985. The second are bulking agents, and the first one that was approved here was deflux in 2001. So we're going to look at the complications that have developed after these things. So with maternal fetal ultrasound, which again became the standard of care in 1985, it had an impact on 7 significant congenital urologic abnormalities. You see the 6 that are listed here are ones we're not going to discuss. But we are going to discuss the impact of fetal ultrasound on duplication anomalies. And this is actually the Mayo Clinic experience. So if you look prior to the advent of when maternal ultrasound became routine, the most common way duplication anomalies presented, over 70%, was following a febrile urinary tract infection. Literally within 1 year after development of fetal ultrasound, where it became the standard of care, it switched. So 70% of duplication anomalies were actually diagnosed on the fetal ultrasound. One thing that's pretty important to see here, and you're going to see why in a little bit, is no matter which era we look at, and still if we go over our data right now, 15% of our duplication anomalies present with the classic history avoiding normally yet wet all the time. The other thing to point out here is prior to the advent of fetal ultrasound, 10% of our duplication anomalies ended up in renal failure with the need for a transplant. These were almost all ureteroceles that had prolapsed and blocked the bladder neck, causing bilateral renal obstruction. So if we look at our ability for the fetal ultrasound to diagnose a duplication anomaly, is there a difference between the duplication anomalies associated with ureterocele versus an ectopic ureter? This is our current data. So of the last recent 100 ureteroceles that we've seen, we prenatally diagnosed 85% of these. However, 15% were not diagnosed on the fetal ultrasound and still presented with a febrile urinary tract infection. If you look at our ectopic ureters, prenatal diagnosis happen in just less than 50%. And if you still look here, urinary incontinence was the way that 40% of our patients basically presented. And we still have a small number, about 15%, that will still not be caught till they present with a febrile urinary tract infection. Well, what's the significance of this congenital ultrasound or the fetal ultrasound in preventing sequelae? And if we look in the past, again, prior to the advent of ultrasound, 70% of our kids had a febrile urinary tract infection. Currently, it's only 13%. Of these with a febrile urinary tract infection, approximately 1/4 were less than 2 months of age. That's really significant. If you have a febrile urinary tract infection at less than 2 months of age, by history, so 30% of those kids should have meningitis. In our experience, it was actually over half of our kids presenting with a febrile urinary tract infection associated with the duplication anomaly had meningitis. 1/3 that developed meningitis developed long-term problems with cerebral palsy and learning disabilities. So that's significant. And here again, if you look at what percentage ended up with a renal transplant or on dialysis before the age of 10, 7%. What an impact the advent of ultrasound has had on these kids. If you can see, our interventions in the neonatal time span have made a remarkable difference in the incidence of these complications. So one of my young junior staff members, Candace, walked up to me one time and I asked her what she was doing. And she says, "Oh, I'm just puncturing her ureterocele." And I basically stopped her and said, "You know, Dr. Granberg, you're actually saving lives." I don't think the concept of how well we have done with management of duplication anomalies in fetuses, the impact that that has had on these young people are really, really seen by the urologist. But we've definitely decreased a 3- to 4-fold decrease in neurologic complications and a 3-fold decrease in these kids ending up in chronic renal failure. So this is one of my favorite quotes. If all you have is a hammer, you have a tendency to look for nails. So if you only approach a urologic problem with one operation in your quiver, sometimes you don't realize the other things that you should be looking for. So the Mayo Clinic definitely had a hammer that they used on everything with the duplication anomalies. The Mayo brothers, clear back in 1915, basically said that if you had a duplication anomaly, we are only going to manage this in this fashion. And for over 7 decades, the Mayo Clinic only managed duplication anomalies with a partial nephrectomy. This is going to outline their standard of care that they basically use, but all duplication anomalies had a pre-op VCUG. The Mayo brothers said you had to identify the ectopic ureter orifice. So they would do a cystoscopy and vaginoscopy, look over the old records, sometimes for hours, trying to find this ectopic ureter orifice. If they couldn't find it, at the time they did the partial nephrectomy, they left a stent in the ureteral stump so they could do a study later on to see where it drained. At the time they did their partial nephrectomy, they excised the ureter down to the common sheath. They always took a culture of the upper pole urine. So if it wasn't making any urine, they would barbotage this with normal saline and send a culture out. All refluxing ureters on the proximal end were ligated. Non-refluxing ureters were drained and left open. So the protocol, which they followed for 70 years, said that all patients with a duplication anomaly had to have a VCUG done 3 months postoperatively. So let's go back and look at what happened from 1982 to 1991. I came to the clinic in 1991 and was pretty appalled that we were doing partial nephrectomies for all duplication anomalies. So we gathered the data at that time over the last 100 and some patients that we had seen, and there are some real key points that I want. So all patients, irrespective if they had a febrile urinary tract infection on presentation, remember these were predominantly before the advent of fetal ultrasound, versus those that were diagnosed on the maternal or fetal ultrasound. One thing that I want to point out, remember, if they're presenting with a febrile urinary tract infection, look at this, 40% of the patients had chronic pyelonephritis of the upper pole. Now, in the days when the Mayo brothers developed this operation, there was no good antibiotics. So they didn't want to leave these segments in for fear that they would impact the lower pole functioning kidney. That's why they were doing the partial nephrectomies. However, after the advent of fetal ultrasound, we were only seeing 10% of kids with chronic pyelonephritis of the upper pole. So the findings of pyelonephritis in the upper pole on our histologic specimen was highly related to the patient's history of a febrile urinary tract infection. If they had a history of febrile urinary tract infection, 40% had infected upper poles with chronic pyelonephritis. If they had negative history, we still found chronic pyelonephritis, but it was in more in the 10% range. That was highly significant. So here's the hypothesis that we developed. We thought that if congenital duplication anomalies diagnosed by a fetal ultrasound and without a history of febrile urinary tract infection, we could keep the upper pole rather than doing everything that the Mayo brothers had stated. We thought there'd be a low risk, only 10% risk for chronic pyelonephritis. We had no idea what the risk for hypertension was by retaining the upper pole. And we thought that minimal invasive surgery should be followed on these individuals. In turn, though, if we felt that a congenital duplication anomaly was diagnosed following a febrile urinary tract infection, and that is still, even with the maternal and fetal ultrasound, about 15% of the kids with duplication anomalies, they would have a 40% risk for chronic pyelonephritis. And if we did anything to obstruct this upper pole or do a UU, we would infect the lower pole in about 40% of kids. We had an unknown risk for hypertension for leaving the upper pole in place. And we thought that these individuals, if they had a history of febrile urinary tract infection at the time of diagnosis, would have a higher risk for long-term complications following any minimally invasive surgical procedure. So, how to prove this hypothesis? Well, we do a transitional clinic where we see kids just over 18 years of age with any congenital pediatric problems. And we were following 115 patients with duplication anomalies, 99% managed by partial nephrectomy. 87 of these patients have been diagnosed following a febrile urinary tract infection. So basically, the upper pole's gone. We're going to see what happens in long-term follow-up. 8 to 24 years after their partial nephrectomy, 10% had become hypertensive, 14% were still having recurrent urinary tract infections. If we look at the individuals managed by a partial nephrectomy diagnosed on congenital ultrasound, 8% of our patients became hypertensive. Again, that's in a follow-up of 15, median follow-up of 15 years. 17% had recurrent urinary tract infections. So if you look at the group here, and again, I'm repeating myself, but these are duplication anomalies managed with partial nephrectomies. The hypertensive rate is not different if we do partial nephrectomies on these difference between kids diagnosed with febrile urinary tract infection on recurrent urinary tract infections, nor do they have more incidence of recurrent urinary tract infections. So this is our baseline if all people are managed with partial nephroureterectomy. That's not what we're necessarily interested in, but we had to have a baseline to say what happens to these kids. So then we had 16 patients that we followed that were all managed with a ureterostomy. All of these kids have been diagnosed on fetal ultrasound. It's very important to note, and I want to stress this, none of these 16 patients had a history of febrile urinary tract infections. What happened, again, on a median follow-up of 15 years? 6% became hypertensive, 12% developed recurrent urinary tract infections. Very similar to the data you last saw. So if we compare this, if we retain the upper pole, again, I'm stressing the point, no history of febrile urinary tract infections, versus the classic Mayo way of doing partial nephrectomy, the hypertensive rates were really no difference with the retained upper pole. And the recurrent urinary tract infections were no difference with the retained upper pole. I'm going to go back to stress one thing. None of these patients had a history of febrile urinary tract infections. So this paper that we wrote here down here with Dr. Levy is probably the most quoted paper on popularization of minimally invasive surgery for duplication kidneys with salvation of the upper pole. And it's frequently quoted right out of these papers that there's no increased risk for retaining dysplastic upper poles of a duplicated kidney. Almost none of the authors that quote us mention that they failed to mention that we looked at febrile urinary tract infections and chronic pyelonephritis. Their statement is right up in here. So most of the current methods for minimally invasive are not looking at kids with febrile urinary tract infections. So what became popular? Laparoscopic clipping of ectopic ureters, very minimal procedure. Ipsilateral ureterostomy for duplication anomalies of both ectopic and ureteroceles. Well, let's look at probably one of the best papers that have recently been written on ureteral clipping of ectopic ureters. And interestingly, these authors clipped ectopic ureters that presented with incontinence. So these weren't diagnosed fetally. And in this paper, there is no history of a prior urinary tract infection. 91% successful. That's pretty decent. 3% eventually underwent a partial nephrectomy due to upper pole dilation and pain. 6% had a single non-febrile urinary tract infection. Follow-up, however, is relatively short, less than 2 years. Well, I'd caution people to not jump on that bandwagon so fast, and I'm going to show why. With the experience with partial nephrectomy, we frequently saw ureteral stump syndrome, and the symptoms arising to secondary ureteral stump were well outlined by Dr. Malik in a paper dating back to 1971. Most of these are intuitive because these are the same symptoms you get with a urethral diverticulum. However, he does have two that are not commonly thought of. One is he did see recurrent bacterial vaginitis due to an ectopic ureter that emptied into the Mullerian system. And he had a few people that developed a vaginal cyst. Distal portion of the ectopic ureter became stenotic, collected pus and purulence, and developed a stump empyema. Again, one important thing is we identified where all ectopic ureters drained at the Mayo Clinic. The Mayo brothers forced us into doing that. One nice thing about that data is we found out that approximately 40% of these ended up into the urethra, and 60% ended up into the Mullerian structures or the distal vagina. And separating these two out actually becomes quite critical. So let's first look at ectopic ureters that are draining into the Mullerian system and the distal vagina. And we have 117 patients we followed. Look at this. Secondary surgery was only needed in 3%. That's remarkable. I mean, if you look at that, if you're draining an ectopic ureter in the Mullerian system or distal vagina, you're doing your partial nephrectomy or your minimal invasive procedures, probably not going to get you into any trouble. One very interesting data that we could find from this is since we were forced to do positive cultures of the upper pole, we saw that none of the patients that had a negative culture of the upper pole required treatment for a ureteral stump syndrome. However, if they had a positive culture, now remember, we're taking out all these proximal ureters in upper poles, 12% eventually had problems with the distal ureteral stump. I'm not sure how I can explain this. You would have thought that if you took out the upper pole, you drained the system and put them on antibiotics, this wouldn't be related to stump syndrome. All I can say is our data suggests that it is. So if I have an ectopic ureteral draining into a Mullerian system and distal vagina, what does this mean to me? Well, first of all, if I have an upper pole ectopic and there's no history of infection, and we still do urine cultures at the time that we do a partial nephrectomy or minimal invasive procedure of the upper pole, we believe that's a perfect candidate for doing something minimal, such as ureteral clipping. If, however, we'll do a culture and a gram stain from the urine with the upper pole, if that's positive, then we're very concerned about leaving that upper pole in place. Now, this should mean, if this is positive, that we got about a 10 to 20% chance of late complications if I clip that ureter, either from a kidney infection from a retained upper pole or from a possible ureteral stump syndrome. So part of our standard of care, if we're going to do a minimally invasive clipping for an ectopic ureter, is to obtain a urine culture of the upper pole. Now, remember, we had individuals who were draining into the urethra, which is about 40% of our patients here. All of our patients had a VCUG pre and post-op. If they never refluxed, 60% never refluxed, 15% that refluxed pre-op resolved on the post-op. We had some who only refluxed post-op, and we had some that refluxed on both studies. Well, what's that mean? So if they never refluxed on any of our studies, basically these are very amenable to a minimally invasive procedure. However, they refluxed at any time, this is pre or post, 1/3 would develop problems with recurrent urinary tract infections. But really what's important I want to stress here is that if you were getting a reflux found on the post-op VCUG, over 50% of these patients had recurrent urinary tract infection. In essence, that ectopic ureter acting like a urethral diverticulum. So in these 68 patients, how many did we have to actually treat for ureteral stump syndrome? 10%. All of these had post-op reflux into the stump on a post-op VCUG. We excised the stump on 3 people, and we fulgurated the stump on 3 of these individuals, and all resolved their symptoms. I'm going to turn a little bit. So this is ureteral stump syndrome that's presenting to us in a transitional clinic. So these are individuals who have had a partial nephrectomy or something performed, UU. The distal ureter was left in place. And they're presenting to the transitional clinic 14 years as a median time span after that they had had their operation performed by the pediatric urologist. All of these patients had ectopy into the urethra, which is the high-risk group. Interestingly, all had seen a pediatric urologist with recurrent urinary tract infections 18 months to 3 years after their procedure. All had had a pre-op VCUG obtained. 20% had reflux into the ectopic upper pole pre-op. 80% did not have reflux pre-op. I'm going to stress one thing. Even though they presented to their pediatric urologist with recurrent urinary tract infections 18 months to 3 years after their procedure, none of them had a post-op VCG obtained prior to referral. What did the pediatric urologist do to treat their recurrent urinary tract infections? All of these 10 patients had been treated for voiding dysfunction. So, what happened to these kids after they left the pediatric urologist office? What's the cost of missing this ureteral stump diagnosis. So we're seeing these individuals as an adult. 100% had multiple recurrent urinary tract infections. I think the least one that I counted was 25. 100% had post-void dribbling, like a urethral diverticulum. 40% had dyspareunia, like a urethral diverticulum. 20% had developed chronic pelvic pain, some of which had become narcotic dependent. I think this is amazing. 1/3 of these patients had seen a urogynecologist before we saw them in our transitional clinic and had slings placed for incontinence. 10% actually had urethral bulking agent placed for urinary incontinence. And even though they had been seen by the pediatric urologist, and all of these had been seen by either an adult urologist or urogynecologist, nobody had obtained a VCUG prior to referral. That's in the known history of a duplication anomaly. So the first thing we did was get a VCUG, and all 10 of these patients had reflux into a stump. 60%, those with dyspareunia or chronic pain, we were afraid to fulgurate that stump, so we actually did a formal operation where we removed the excision, the ureteral stump. 40%, those that did not have dyspareunia or chronic pain, we actually fulgurated the distal stump using a Bug-B electrode. I'd love to say everything went well. Well, 100% had the resolution of the reflux in the stump. 90% of our patients had relief of symptoms, but I do have one patient who has persistent and chronic pelvic pain that we can't stop with treatment. So what do I do with this information? Well, reflux into an ectopic ureter is extremely important, as we've already pointed out. And the findings of reflux into an ectopic ureter post-surgery is a critical finding related to recurrent urinary tract infections and symptomatic ureteral stump syndrome. So how do we approach the patient with duplication and ectopy? We still do a pre-op VCUG. We do a cystoscopy and vaginoscopy looking for where the ectopic opening is. We strongly consider or perform doing a CT or MRI, looking mainly to see, does this empty into a Mullerian or distal vagina? If it is, you can get away, strong chance you're going to be able to get away with a minimally invasive disease. If it's opening into urethra, then we're much more concerned with whether or not there's going to be problems with reflux into that ectopic urethra. What do we do if we see reflux in the pre-op? Do we fulgurate the stump? Do we observe? I think that's going to be up to the surgeon. However, if that patient presents with recurrent urinary tract infection, and that's no matter how you treat this individual duplication ectomy, post-treatment, we strongly believe that a VCUG is mandatory. And if you have a refluxing stump, we would highly recommend treating it. So let's change a little bit. So let's look at the state of the arts, because here's the other minimally invasive procedure that a lot of people are doing for duplication anomalies. It's a ureter or ureterostomy for the duplication anomalies of either ectopy or ureterocele. And there's a very nice paper out here that's by Dr. Harms and Associates in the Journal of Pediatric Urology. And they did ipsilateral ureterostomy, no lower pole reflux in these patients. But I would point out this, 45% of the patients had a history of febrile urinary tract infection. When I read this paper and I saw that, I said, whoa, how much problems are they going to get into? Our data would suggest a lot. Here's actually what they report. 91% success. Only 5% had recurrent febrile urinary tract infections and new onset of vesicular reflux. That was actually to the entire system, so they underwent a ureter reimplant. One patient had reflux into a ureteral stump. One patient had febrile urinary tract infection, and they didn't state why. Now their follow-up, I'm going to point out again, was short. It's 20 months. It's not even 2 years. And I'm going to be saying, I'm a little concerned about jumping on this, especially when you're jumping on with 45% of these patients having a history of febrile urinary tract infection, our data would say that at least 30% of these should have gotten into trouble. So here's the question. In our transitional clinic, have we seen complications of a retained upper pole following a ureterostomy? Have we seen chronic pyelonephritis develop in the lower pole following a UU? So we have 13 patients that we are following that have had a UU in our transitional clinic. Median follow-up's 18 years. Now, 60% of these patients had no history of febrile urinary tract infection, incontinence only. As far as I'm concerned, these would be the perfect people to do a UU on. Did we see problems? Yes. We have one of these 8 patients have post-op recurrent febrile urinary tract infections. We did find a reflux and ureteral stump. We fulgurated it, and she is free from all symptoms. Here's the patients that I'm worried about. 1/3 of our patients had a history of pre-op febrile urinary tract infection and incontinence, and were managed with a ureterostomy. Again, our data would have suggested that about 40% of these people should have gotten into problems. What have we seen in long-term follow-up? Well, small patient population, but 60% of ours did see their pediatric urologist with recurrent febrile urinary tract infection within 2 years of them having their surgery. What did the pediatric urologist do? Well, these pediatric urologists were very smart. They all got a postoperative VCUG that was negative. They all did a renal ultrasound that revealed no obstruction where they had done their UU. To prove it to themselves, they did MAG3 upper pole, which either had shed forward and no function, but again, no evidence of obstruction. And what happened? All of these patients were treated for their voiding dysfunction. Classic pediatric urologist, if you're getting recurrent urinary tract infections, don't find anything, it must be voiding dysfunction. Well, what happened to these patients? Well, 3 of these 5 patients presented to us between 22 to 28 years of age with a history of multiple urinary tract infections for 10 years. 1 of the 3 had lost a pregnancy secondary to febrile urinary tract infection when she was pregnant, combined with eclampsia. All 3 patients at the time that we evaluated them had less than 10% function of the kidney that had been operated on, whereas at the time they had their actual UU, these kidneys were at least 40 to 50% of the function. All 3 patients, even with a repeat VCG, was negative for reflux. I was so paranoid thinking that there had to be obstruction. We actually did Whittaker tests of the upper poles, which were negative for obstruction. And we finally went in, we did nephroureterectomies in these 3 patients, all with chronic pyelonephritis, the upper and lower pole. And I'm pretty sure that these individuals probably had chronic pyelonephritis of the upper pole at the time that they did the UU, and people just missed that the chronic infections were coming from the upper tracts. So what are the lessons to be learned? Duplication anomalies diagnosed on maternal ultrasound and no history of a febrile urinary tract infection. I think minimally invasive surgery is extremely practical. You have to absolutely beware of patients with a history of a febrile urinary tract infection with a duplication anomaly. Our data would suggest that there's a 30 to 40% chance of chronic pyelonephritis of the upper pole. And I really think that this is a place for shared decision-making. You can get by with a minimally invasive operation, but you are putting this patient at possible risk. So lessons to be learned. Be very aware of postoperative urinary tract infections or chronic vaginitis following reconstruction of duplication anomalies. These are the things that we classically do when we see them in the transitional care. They all get a VCUG because we're concerned about vesicular reflux and ureteral stump. If they're getting chronic vaginitis, and I have to say I'm also worried about that with just a duplication anomaly, I will frequently get an MRI or CT looking to see if we have a ureteral stump empyema someplace by the Mullerian duct. We want to verify that we have no obstruction at the UU site, so renal ultrasound and MAG3 scans. And we do look for infected upper pole causing pyelonephritis. We'll either do selective urine cultures. Classically, this may be by a percutaneous puncture, or we'll do a tagged white blood cell scan. This is how we usually begin. Going to change the entire topic. So we're looking at the other thing that really impacted us in transitional care, and that's the use of bulking agents in a pediatric urology. So what are we seeing? Are we seeing long-term problems with these in transitional clinic? Well, this is my feeling with bulking agents. When they are good, they are very, very good. And when they are bad, they are horrid. So I'm going to show you some major complications we have seen with bulking agents in pediatric urology from treatment by pediatric urologists. Well, what injectable agents were used to treat, and how often do they calcify? Calcium hydroxyapatite is immediately radiodense. You're going to see it right after you inject it. Deflux is very interesting because the ultrasound shows calcification of 3% at 3 years, 8% at 8 years. I love how easy that is to remember, 3 at 3 and 8 at 8. But if you do a CT scan, 30% will be calcified on CT scan by 5 years. If you look at macroplastique, calcification is actually recorded. The true incidence of calcification after macroplastique is unknown. Well, here's one of the first patients we ran into. So here's a 22-year-old woman, and she had been treated for a problem with reflux when she was 2. And other than she had an operation, she didn't remember anything about it. She now presents and had a urinary tract infection in early childhood. She presents now with intermittent left flank pain, and look at the CT scan that the original urologist saw. And here they are with their ureteroscope in place. So we have 5 patients where no history of vesicular reflux treatment was obtained in the patient at the time they saw their adult urologist. The patients didn't even know that they had had an injectable procedure performed. They were seen in the ER evaluation for abdominal and flank pain. All were adults with no prior knowledge of treatment. All of them showed CT scans with stone. The adult urologist did a ureteroscopy. They saw these yellow plaques submucosally. They thought they were stones. All lasered these submucosal yellow plaques. And what happened? Wow, why did they get sent to us? 40% developed a pelvic abscess post-op. They got sent to us in dire straits with urosepsis, pelvic abscess formation that we had to put percutaneous pelvic drainage in and percutaneous nephrostomy tubes. All developed dense ureteral strictures at the site that they had the laser of their, quote, stone, unquote. We did fix all of these with the ureteral neurocystotomies, with the psoas hitch, plus or minus a Bori flap. Let me tell you, some of these operations were immensely difficult because of the amount of pelvic phlegmon that was present even 3 to 4 months after the original surgery. Here's another interesting patient. 24-year-old woman with spina bifida, status post-sling and urethral bulking procedure with deflux for incontinence. As a kid, now shows up in my clinic as an adult. She is completely continent. However, she says she's been having increasing dyspareunia and increasing pelvic pain for the past 1 to 2 years. So let's look at this MRI we have. Oh my gosh. I saw that. My first thought is, what is this? This has actually been very well reported by doctors Leitner and Rovner. And this is actually a deflux pseudoabscess. So this is an abscess or pseudocyst, but it's not truly infected. It's a mucus cyst that forms around deflux if you inject more than 4 cc's. So we aspirated this. It was negative for bacteria. Originally, I tried to drain this from the vagina. That was a total catastrophe. It was very loculated, so I had to turn her up and actually do a suprapubic incision and drainage. After we drained this, she became diaper dependent. 1 year later, I tried to go back in and do a sling and a bladder neck reconstruction, which failed. And eventually, I had to do a bladder neck closure, augmentation, and continence stoma. Here's another patient, 22-year-old female with exstrophy. Status post-stage bladder closure with bladder neck bulking with macroplastique 10 years ago. She was having problems with being incontinent and recurrent urinary tract infections when she originally saw her adult urologist. This picture was taken after the adult urologist she saw had actually TUR'd this stuff out. And you can see the bladder neck reconstruction. He TUR'd the bladder neck. It's now wide open, and I have lots of this macroplastique showing through. So we've had 3 patients with exstrophy with bladder neck reconstruction treated with macroplastique or calcium hydroxylate, erosions into the bladder following bulking procedures. All treated elsewhere with TUR resection of the foreign body and bladder neck. This resulted in, again, my friend here, the pelvic urinoma and abscess in 2 patients after they resected it, chronic urinary incontinence in the 1 patient whose pictures you saw. We had to put in our bilateral nephrostomy tubes and pelvic drains to get 2 of these patients to get over their abscess. And we then went back in and we closed the bladder neck, augmenting incontinence stoma in all 3. 1 of these patients who had developed a urinary abscess, I went back in and closed the bladder neck 2 more times. All 3 bladder necks failed. I did not want to use a rectus, part of the rectus, to close the abdominal wall because the rectus was very poor in this patient with exstrophy. So she ended up with an ileal conduit. Here's 3 male patients with spina bifida treated with macroplastique or calcium hydroxylate for incontinence on CIC per urethra. So these have all been treated by the pediatric urologist. I'm going to point out one thing. All of these patients had mental intellectual disabilities, and the patients were being catheterized by a surrogate. So they presented to our transitional clinic, were referred because they were getting febrile urinary tract infections. Their creatinine was rising quite high. They had new onset of bilateral hydroureter nephrosis. First one of these I did a cystoscopy. I had multiple urethral falls passages, but I didn't see any signs of erosion. Entering the bladder with a flexible scope was highly problematic. The first one of these, I was having the resident scope. The resident spent 5 to 10 minutes, couldn't get through. I said, well, give me the scope. I spent about 15 minutes to get through, and then I handed the scope back to the resident. I mean, these were impossible to get through. All 3 patients eventually were managed with a suprapubic tube. All 3 now have stage 4 chronic renal failure. So what to make of this? Have I used bulking agents for incontinence? Yes, usually as a Hail Mary, final solution following a failed bladder neck reconstruction in exstrophy patients. What's my personal experience? We had 15 patients that failed bladder neck reconstruction. I have only used deflux. I was very cautious to not get over the 4 cc's. 1/3 of our patients are continent for 5 to 10 years. 2/3, it absolutely did not work. And we ended up closing the bladder neck, augmenting, and creating an abdominal stoma. So should you be concerned? Well, deflux is definitely at risk for pseudocyst formation. If you're going to use this for a bulking agent, never use more than 4 milliliters. I personally would use for a bulking agent right now. I no longer use this for a bulking agent, calcium hydroxylate or macroplastique. Bad thing about this is these can erode and cause false channels. These also aren't a panacea. And I am much more aware of the long-term consequences of injecting a bulking agent. I used to think that this was like fairy dust. Let's just go in and sprinkle a little of this. These do have complications. Thank you very much for your time.
Thank you very much, dear Doug. Amazing presentation. I will give the word to Anthony to make some comments about this amazing presentation. Please, Tony.
Yeah, great job. I remember hearing bits of this a couple of years ago, but this was in much more detail than I recall. And it's an experience that I think very few of us in pediatric urology or in transitional urology have had the depth of and the robustness of the experience that you've had at the Mayo Clinic, and also been able to categorize it into some useful information. A couple of questions, maybe one on each of the topics that you presented. Let's talk about the bulking agent for just a second, and let's focus our attention maybe on the classic bladder exstrophy patient. Not having had a tremendous amount of experience with it, I have not had very good luck with injection procedures to bulk the bladder neck in these situations, even after a bladder neck procedure. So is it even worth a trial of doing that, or do you just should move on if indeed the bladder neck procedure doesn't solve the problem of the incontinence?
So Tony, probably like all the pediatric urologists, when I'm facing this problem, I do a couple things. I do a cystoscopy to see how well things are approximated for the urethra. And I'll also, at the same time, a lot of times I'll have to put this urodynamic catheter that I'm going to use over a zip wire into the bladder, and I'll do urodynamic studies. And if I see that bladder is non-compliant, or if my leak point pressure is less than 40, there's no bulking agent in the world that's going to touch that. And I, personal experience, don't have a lot. Over 60, I have a pretty good success rate if I got a leak point pressure over 60 and a compliant bladder. That 40 to 60 range, in my experience, is very gray, Tony. Yeah. You could possibly try it, but I think I've had one success in that range. Most of the success range I've had is when the leak point pressure is pretty high and the bladder is compliant. And I have to say, as you saw my data, that's only about a third of the patients I've used it in. And I'm very selective on who I use it in, Tony. So the majority, I look in there and say, just like you do, I'm going to close this off and do something else. So even with being extremely selective on who I inject, I get 1/3 of them continent. So not a lot, Tony, not a lot.
And as you said, even if you are moving on to a more aggressive procedure because you failed or because of the urodynamic pattern, it's not a slam dunk to close the bladder neck in these patients either. I mean, that's a complicated operation.
Yeah, we've been pretty fortunate, but as you saw, I have definitely had some failures in my bladder neck closures. I mean, I don't know a single urologist who has done enough of them that have not failed.
Yeah, exactly. And then maybe one question about the first half of your presentation on the ectopic ureter, in particular with the duplicated system. It seems to be clear from your presentation that those who present prenatally without a history of urinary tract infection, a minimally invasive type of procedure with leaving the upper pull in is a safe thing to do in the vast majority of patients. But what is your approach now, understanding all the options that are available, for those that 20 to 30% who may still present with incontinence and chronic urinary tract infection?
Well, if you're presenting with a history of chronic incontinence and urinary tract infection, our data would say that you could get away with a minimally invasive procedure about 60% of the time. So you're going to get stung about 1/3 of the time in those patients. Yeah. The question is, how do you identify those 1/3? So I'm going to tell you that I approach it in a variety of ways, Tony, and if I'm using a variety of ways, that means I'm not happy with any of them. So, so what do I do is I'll frequently do a tagged white cell to see if I'm going to light up the upper pole, and if that lights up, then I'm done, Tony. I'm going to be saying, I got chronic pyelonephritis of the upper pole, that's a problem, all right? The other thing that I'll do is if it's I will, on rare occasions, actually have my interventional radiologist put a needle into that upper pole
Yeah.
and get a urine culture. That's rare. I usually do the tag white cell first because it's not as invasive.
Yeah.
And the other thing is if the tag white cell's negative or equivocal, at the time we do something, I'll actually transect, especially now that everything's robotic or laparoscopic, that upper pole and get a urine culture or barbotage that and send that to microbiology for a stat gram stain from the OR. And if that gram stain's negative, I'm probably going to proceed with salvage of the upper pole. If that gram stain comes back positive, Tony, then I'm sitting there going, I got a problem with this. And I'm not willing to, or you follow me, tie the upper pole to the lower pole. And then I'm basically telling the family that if I find X, I'm going to jump back to the partial nephrectomy. So that's, Tony, probably only about 10 to 15% of the time.
Yeah. Great. Thanks very much. I know there are a lot of questions that have popped up in the chat box, German, so you might want to proceed with those.
Thank you, Tony. Francisca, maybe you can do your question.
Thank you, Doug, for this wonderful talk. So I have the same opinion that Tony regarding the bulking agents. We are not very enthusiastic about them regarding bladder neck, but we have seen a little bit more results with patients that are doing CIC per Mitrofanov. Is that your opinion as well? That if the CIC after the injection is done by Mitrofanov or anterograde, putting the bulking agent, you might have a little bit better results.
Okay. I personally tried antegrade. I haven't been overly enthusiastic about it, but I have seen it done. And I have seen if I have a nice compliant bladder with Mitrofanov and I do a urodynamic study and the leak point pressure is kind of in that moderate range where it's over 40, that those people can absolutely, with the Mitrofanov, get dry from below. Provided one thing, is a transitional or congenital urologist, you know where you see them get into problems is not as kids, as an adult when they get obese. So once they get extra weight in adulthood, I've seen them start leaking like gangbusters through the bulking agents in that standpoint. So this is certainly one time where following these people as they get older and stressing to them how important nutrition is, or even using now some of the GL1 blockers so you keep our patients fairly thin could be a huge benefit and prevent complications. I know urologists don't like to talk about obesity as a complications for operation, but unfortunately, in my group and in the United States, that's a real problem.
But Doug, because after getting an injection, doing a sling, it's very troublesome. So maybe we should discourage doing this bulking agent at all, because as you can see, patient getting older, gaining weight, and then dealing with the bladder neck with repeated bulking agents and stuff like that, it's very difficult. So maybe we should stop doing that for all patients. It's very easy. That's what is tempting doing it. But at the end, the results are poor and long-term complication might be very troublesome.
I would agree with you. Having closed these or attempted to close these after the bulking agents and all these calcified materials are infected laying in the pelvis, and you're trying to clean out all this infected pelvic material and close the bladder neck, it's a real problem. So as I alluded to, Tony, I'm very cautious on using it. I used to treat it like fairy dust, thinking it was great. Let's just go sprinkle this stuff in. And now I have to say I am very, very cautious on whom I use it in. So I would agree with you. I think backing off on how much we're using is probably merited.
We have another question here from Dr. George. Congratulations, Doug. What is your opinion about the management of urethrocyte with resection and reconstruction of the vesical floor?
So I'm going to repeat the question as I understand it. So he's asking resection or puncture of the urethrocoel?
Resection and reconstruction of the vesical floor.
So I usually...
Hello.
Yes.
Hi, Dr. Dog. Nice to meet you again. We were in Dallas
Yes. Yes.
the last year. I see Anthony. Hello, Anthony, too, and Germán. My question is about the reconstruction, the low reconstructions in patients with problems after the the reconstructions like uretero anastomosis or inclusive partial nephrectomy of upper pole. And I have patients especially young patients with problems like incontinence and urinary tract infections and other problems. And after that, I make a transvesicoscopy, a robotic way, and resection of the remnants of ureterocele and reconstructions of the pelvic, the vesical floor. What do you think about that?
I have actually done very similar operations, usually open, not robotically. But yes, I have usually, if they're giving me problems, resected the ureterocele and reconstructed, do a total reconstruction, just like you mentioned. I will have to say, though, having done that, is I have seen some voiding dysfunction following that repair. So that made me be interested. So I studied ureteroceles who didn't undergo that repair and saw that a fair number of those, even as adults, especially with ectopic ureteroceles, have a voiding dysfunction. So I was going to attribute the voiding dysfunction to my operation, which some still could be. But I think that there's a subset, and we've actually written about this, of people with ectopic ureteroceles that have a permanent voiding dysfunction that's going to cause them to get recurrent urinary tract infections. And some of these patients for me have had to be on long-term intermittent catheterization. So yes, I do the same thing that you do, and I'm still not necessarily happy. So sometimes I'm very pleased and sometimes not as happy as I would like to be.
Yes, I think so. Thanks, Doug. Nice to see you.
Nice to see you.
Thank you, George. And any
Thanks,
questions?
Germán.
Let me see. No questions. Dear Doug, we appreciate your presentation, your amazing presentation, and thank you very much to be with us this time. And maybe we have another time us inviting you to be with us. Okay? Thank you. Thank you very
Thank you.
much. And
Bye-bye.
thank you.
And Doug, happy birthday tomorrow.
Thank you.
It's a pleasure.
Very good. Thanks.
Happy
Bye-bye.
birthday.
Happy
Bye.
birthday.
Thank you.
Happy
Thank you.
birthday.
Gracias.
Bye.
Gracias a
Nice to
todos.
see you.
Ya mandé
Bye, bye.
el programa del 2026 que ha sido arduo. Está dentro de las invitadas Francisca. Hemos construido un programa con el doctor Anthony Caldamone, con la ayuda de Anthony, un programa que creo que va a ser de la atención de ustedes. Muchas gracias por todo. Doug, thank you very much again. Tony, as always,
Bye.
thank you. Okay?
Good
Bye,
to see
Tony.
everyone.
Nice to
Bye-bye.
see you again.
Take care.
Bye.
Bye-bye.
Gracias, Germán. Bye.
Chao, querido. Chao.
Chao, querido
Chao,
Germán.
Elio. Chao, chao todos.
Chao.